Hello everyone and welcome to the presentation of this journal article. The name of the article is Stereotactic Radiosurgery versus Observation in Small and Medium-Sized Vestibular Schwannoma Patients with Normal Hearing. The authors are Hajikarimloo et al. And this was published in Neurosurgery in April of 2026. My name is Khyber. I'm a fifth-year medical student at the RCSI and UCD Malaysia campus. So quick background, vestibular schwannoma is a benign tumor that originates from Schwann cells of the vestibular portion of the vestibulocochlear nerve. The optimal treatment strategy for small or medium-sized vestibular schwannomas with normal hearing remains controversial. The two options, one of which is observation. Observation carries the risk of gradual hearing loss because the tumor grows, it compresses, and eventually causes ischemia. On the other hand, while stereotactic radiosurgery offers high rates of tumor control, it carries, in theory, radiation-related risks to the cochlea and cranial nerves. This study aims to compare SRS and observation regarding three outcomes, which are hearing preservation, tumor control, and separate neurological outcomes. To break down the study objective, it was to evaluate tumor control and hearing preservation across individuals with a small or medium-sized vestibular schwannomas, which we will define in a second, and normal hearing at presentation, which also we will define in a second. And these patients had to undergo either stereotactic radiosurgery or observation. So to break down the classification of vestibular schwannomas, it's called the Coos grading system. It goes from 1, which is the smallest, to 4, which is the biggest. The way I learned this was that the 1 looks like an I for intracanalicular, 2 sounds like in 2, so into the CP angle, 3 is the T for touch, 3T for touch. So it touches the brainstem, contacts the brainstem. And 4, you just have to remember that once you touch, you also push, so it displaces the brainstem and cranial nerves. Now for the hearing classification, it is the AAO-HNS hearing classification. It's broken down into A, B, C, and D, with A being the best hearing. It uses two values, which are firstly the pure tone average, which is, it answers the question, what is the lowest volume you can hear at? And then at that volume, they create another score, which is called the speech discrimination score. At that volume, how much speech can you understand? That's given as a percentage. So in this paper, they call group A normal hearing. And this is the inclusion criteria, which I'll show you in a second. However, A plus B is what they call serviceable hearing. And that is what they want the patients to maintain in order to be included in the positive outcomes. So serviceable hearing, if you read it in the paper, is both A and B. So moving on to the methodology of the paper. The study design is retrospective, and it's an international multicenter study that analyzes data that was collected by the International Radiosurgery Research Foundation. The inclusion criteria is adults with KOOS grade 1 or 2, so the two smaller sizes, and normal hearing. So if you remember from the previous slide, this is just grade A from the AAO-HNS. And the exclusion criteria are bilateral tumors or neurofibromatosis-related tumors. My understanding is that these are more aggressive and have different pathways of progression to the sporadic form. Importantly, there was no treatment crossover between any patient, so there was no patient who first got observation and then moved on to SRS during the study period. So, statistical analysis. Obviously, in a retrospective study, you will expect some selection bias, so the authors utilized a 1-to-1 propensity score matching system. So they matched patients apples to apples in multiple categories, which were age, sex, tumor volume, pure tone average, and speech discrimination score, both of which are the AAO-HNS criteria. Okay, what were the outcomes? As we mentioned, serviceable hearing preservation was the primary outcome. So this is grade A and B of the AAO-HNS, and the secondary outcome was tumor control and cranial nerve preservation. So here are the baseline characteristics, which I will break down in the next slide, but most importantly, I turn your attention towards the p-values. You can see that almost all are greater than 0.05, which means that the differences between observation and stereotactic radiosurgery are not significant. There is one statistically significant difference, and that is in the number of symptomatic patients that each group had. Observation had only 28, whereas SRS had 47. And having more symptomatic patients could negatively skew the effects or skew the results in the SRS group, but we will discuss that later. Okay, so as we just saw, the matching process successfully yielded 57 patients per group. Baseline demographics and tumor volumes were statistically similar, very important if you're comparing. However, as I just mentioned, the SRS group had a significantly higher proportion of symptomatic patients at baseline, with a p-value of 0.014. Key results. The primary outcome of hearing preservation, let's look at that first. At 5 years, the serviceable hearing preservation rate was 76.2% in the SRS group and 56.1% in the observation group. First glance, you think, wow, hearing was better preserved in the SRS group. However, this difference was not statistically significant, which is very unsatisfactory. So the authors concluded that SRS is non-inferior, so they looked at it with the glass half full approach. SRS is non-inferior to observation for hearing preservation. Here is the Kaplan-Meier curve for hearing preservation probability. You can see that there is overlap in the standard deviations of both. So you can see that the blue SRS group and the red observation group, they overlap. And so you can't really say that there's any significant difference at 5 years, for example. And that's reflected in the p-value. The secondary outcome is tumor control. Stereotactic radiosurgery achieved significantly superior tumor control rates compared to observation. That is very important. With a p-value of less than 0.001, that is very significant. At both 5 and 10 years, tumor control rates were a whopping 97.9% for the stereotactic radiosurgery group, compared to 40.9% and a much lower 15.1% at 5 and 10 years for the observation group. Just a side note to mention, specifically for KOOS grade 1, stereotactic radiosurgery achieved 100% tumor control at both 5 and 9 years. So here's the Kaplan-Meier curve. You can see that it's a huge difference. Even at 5 years, it's a huge difference for tumor control. Finally, the third outcome, neurological outcomes. There wasn't any statistically significant difference between the observation and SRS cohorts regarding the worsening of tinnitus. The rates of cranial nerve function worsening, the other cranial nerves including facial and trigeminal nerves, so 7 and 5 respectively, were comparable between both groups. Just looking at the p-values, they're not significant. So discussions and conclusions. The limitations, the one that we mentioned was that it was retrospective in nature, so there was inherent selection bias. Next, the median follow-up time was shorter than 5 years. Vestibular schwannomas are notoriously slow growing, about 1 to 2 millimeters per year, and therefore longer term comparisons are important, which we didn't necessarily get to see here. Thirdly, the data also lacked exact anatomical tumor locations, such as intracanalicular versus cisternal. This is important when you're considering surgery later on, because intracanalicular, for example, has more complicated surgeries, such as drilling of the internal auditory meatus. So we weren't able to consider that. Fourthly, the study didn't capture the time interval from diagnosis to intervention. And that introduces bias, because when you're evaluating time-sensitive endpoints, like tumor progression or hearing decline, you can't compare. Finally, there was baseline asymmetry. Despite the propensity score matching, the SRS group did retain a significantly higher percentage of symptomatic patients. And as we have said, that probably did negatively skew the hearing-related outcomes for the SRS. To conclude, the authors said that SRS is superior to observation for achieving durable tumor control in small to medium vestibular schwannomas with normal hearing. At the same time, hearing preservation outcomes with upfront SRS were found to be non-inferior to active observation. So what does this mean for neurosurgeons? The paper says that proactive SRS is better than observation if you're looking at this population. It achieves significantly superior long-term control. 97.9% versus 15.1% at 10 years is huge. Secondly, for hearing outcomes, SRS is non-inferior. It appears, according to this paper's data, that radiation does not accelerate hearing loss any more than natural tumor progression. Thirdly, strongly consider SRS for this population of small or medium tumors with normal hearing at presentation. Finally, despite all three of the above points, the management strategy that you use should still factor in lesion behavior, hearing trajectory, and one of the most, if not the most important, is patient preferences.